Houssem, what are your thoughts with this and what we need to do to retain nurses and also to create safe spaces?
Absolutely, yes. Like I've talked earlier about the three R's that we have: return, and recruitment. I'm going to add the four R, which is respect. So
Mm.
when nurses feel respected, they will feel safe. They feel like they are included.
Welcome to Safe Space Made Simple, a practical podcast that guides clinical leaders and healthcare managers to create trust and support with their teams. I'm your host, Trace Hobson. Join me for weekly interviews, practical tools, and inspiring transformational stories of bringing people together in healthcare. Now, let's dive in. Hi, everybody. Welcome to Safe Space Made Simple. In this episode today, we have two incredibly passionate individuals that work within healthcare, Natalie DuchetteStaké-Doucet and Houssem Adeen Ben Ahmed. Natalie is a nurse activist that works here in Canada, and Houssem is a researcher. In this episode, we have a candid conversation about the state of nursing in Canadian healthcare and what it is that we need to do to create a safe space for nurses. I'm really excited about today's episode. So, without further ado, let's get right into the show. Welcome, Natalie and Houssem, to the podcast. Really appreciate you being here. I've been excited to talk with both of you, waiting for it to come on the calendar. What would be great is if we started off with if both of you could share a little bit about your work and what you're really passionate about right now in your work. And why don't we start with you, Natalie, and then we'll go to you, Houssem.
Sure. So I'm a registered nurse. I'm also an assistant professor at the University of Montreal, the Faculty of Nursing. And first and foremost, I am a nurse activist. My passion is nurses. I think nursing as a profession is the most incredible job there is out there, but we're not allowed to do our job as we should be able to do. We are such an asset to, not just an asset, we are the beating heart of the healthcare system, also the brains in a lot of ways. And it's just, I feel a lot of the issues in healthcare are really related to not treating nurses as humans, but treating us more as, furniture, basically moving us around and not understanding the humanity that we bring, the humans that we are. And so that's really sort of my thing, I guess you could say,
Mm.
both in terms of research, but also in terms of activism. I'm a member of the board of the Quebec Nurses Association, whose mission is to help nurses develop their own political voices and increase the space that nurses are taking up in the political arena, both on in the media, but also in formal political assemblies as well.
Amazing work, Natalie. Thank you for that. Houssem, what about you?
Yes, so my name is Houssem Adeen Ben Ahmed. I'm a senior research associate and a part-time professor at the Canadian Health Workforce Network, University of Ottawa. So I've been working with Dr. Ivy Bourgeot for almost or more than 2 years, on nursing workforce issues. So my main, passion is like nursing education, nursing workforce, and especially issues related to internationally educated nurses, because we have a lot here in Canada, but they are not they don't work, most of them, and also any other issues related to work environments where nurses are working. And now we are working in one of the, I guess, a mega project, it's developing a psychological and health safety toolkit with the Mental Health Commission of Canada. So it will be launched in March, I think, in just like few weeks about this, but how we can create a safe work environment for healthcare workers. So those are my main topics of interest.
Yeah, we'll talk more about that toolkit when it comes out. I'm looking forward to that, the release of that as well. That's going to be great. And we'll include that in future episodes. One of the things that I thought was really interesting in hearing you talk on an interview, Natalie, is that in your perspective, we don't have a healthcare crisis, we have a nursing crisis. And so I'm really curious about what both of you think about that statement. Natalie, you said it. So what do you think about it, or what were you trying to express? And then Houssem, I'd love to hear your thoughts too. Why do we have a nursing crisis in this country today?
So for me, a lot of the issues that we see in healthcare right now, from wait times to the so-called shortage of nurses, a lot of it relates to nursing care, access to nursing care, and where nurses actually do work. So, what especially sort of, how would I put this politely? What really bothers me, let's just say it like that, is this constant complaining of a nursing shortage. If you look at papers, we've had a so-called nursing shortage. Politicians, especially health ministers from provinces and federal governments, and not just in Canada but around the world, have been talking about a nursing shortage since, as the furthest I've been looking in actual government reports and organization reports, is from 1948, and there never has been a year since then that has not had some sort of report talking about a nursing shortage. So at some point, we have to stop talking about nursing shortage and start thinking about nurse retention and attracting nurses into the workforce as well. Part of the idea of the shortage and the way that a lot of politicians frame the problems we're seeing in healthcare right now, sort of, I got to stop saying sort of, the way politicians speak about the crisis in healthcare and the problems that we see in healthcare and social services tends to shift the responsibility from the decision makers onto issues that are out of their control.
Right.
I've heard so many politicians say there's nothing we can do. There are no nurses. We can't have safe patient to nurse ratios because there are no nurses. But the reason we have unsafe nurse to patient ratios, the reason we don't have enough nurses in the healthcare system is because we don't have safe nurse to patient ratios. So we have to start looking at it in different ways and not looking at the so-called nursing shortage as the root of the problem, but everything that drives nurses out of the healthcare system as the root of the problem. And until we do, we're going to be, trying to, shovel water out of a sinking boat without patching the hole.
Right.
And so for me, it's a deeply political question that most politicians over the last at least 30, 40 years have refused to address the root causes. They'll put band-aid solutions on that they know won't work, but that will help them get reelected. And so nurses and the healthcare system as a whole are often at the mercy of different politicians, different elections. We have very little long-term vision for our healthcare system in this country.
This is really interesting because I was just having a conversation with an executive director who's part of a healthcare system. And originally, when she came to this country, she was coming from Europe and really struggled to be able to transition her nursing credential into the country of Canada. Now, we're talking about probably 30 years ago. And so I was really surprised by that because obviously I've talked with you, Houssem, about this, and your research really double clicks on this. And I thought, this has been going on for a very long time, to your point, Natalie. So thank you for highlighting that. I wonder, if you could speak to that a little bit, Houssem, and, we have a nursing crisis. And how does this relate to your work and some of the work that you've done recently with the research that you've been doing?
Absolutely. Yeah, this is an excellent question, Trey. Thank you. So, we talk about nursing crisis because nurses are the backbone of healthcare system, and we can see the largest group of healthcare workers are nurses. So imagine if nurses are leaving their profession or their position, who will treat patients? So we have an amazing role. It's very, very important. So now when I did the report with the Canadian Federation of Nurses Unions and the Canadian Health Workforce Network, I was reading the reports that were published, and for decades, I can say 2 decades, and I'm seeing the same recommendations are just suggested several times, and there is no actions. So this, I was wondering why should I repeat the same recommendations and that were published 20 years ago, right? So this led to this crisis, and why many nurses are not feeling good. So I really like something what Linda Silas, the president of Canadian Federation for Nurses Union, she said, we don't need to throw money just to do service for nurses to check if they are feel good or not. We know they are not feeling good. Now we need to move to actions and to see how we can improve that. And one of the ways that we found in the report that internationally educated nurses here in Canada are unemployed. And you have just said 30 years ago, that nurse, she struggled with this. Now it's the same thing. I'm still internationally educated nurse. I'm doing a great job. I'm not going to talk about myself, but also if we see what was published in the Canadian Journal of Nursing and Leadership by my colleagues Siobhan and Bukola Salami, that there are two big issues on nursing, especially nursing with the educational workforce. The first one, that we have shortages of PhD prepared, like we don't have enough students that are in PhD programs on nursing. And also take a second point, that there is a lack of diversity in nursing education and leadership. So this, just we are wondering who will teach nurses in the future if we don't have this diversity and enough professors in the workforce. This is like a big question that I'm asking, and that's why like all my works now I'm focusing on this area to see how we can bring internationally educated nurses who would like to join the nursing faculty workforce, because most of works are focusing on nursing workforce but not faculty workforce. So that's why like I think should be more coordinated approach between universities and nursing boards to see how we can target this gap that we have in nursing faculty workforce. And yeah, I think this is like what brings me to this topic. And to see like how we can, that nursing boards see like what are the innovative interventions that we can implement to bring these nurses who would like to join the nursing faculty workforce in a clinical or in academia, like this in this area, to see how we can use or benefits from the international expertise of these nurses to teach our nursing students. So this like create big workload for nurses who are already teaching. Like now, I just like today I talked with a friend of mine. She said like, I cannot work anymore because now I have a lot of work and I don't know what to do. So just imagining like bringing more internationally educated nurses, of course, taking into consideration the safe and the quality of services, for patients, and see how we can release, I think, or reduce the nursing faculty workload.
Thank you for that. So I want to refer to your research because you're talking about the research that you've done, and the paper is called Sustaining Nursing in Canada, a set of coordinated evidence-based solutions targeted to support the nursing workforce now and into the future. And that was done with the support of the Canadian Federation of Nurses Unions. And so I think about, and some of the stats in there were just staggering. 94% of nurses suffering from symptoms of burnout and 45% experiencing severe burnout, according to the 2022 CFNU survey. So as I look at this, I want to just talk a little bit more about the root cause, because it's just so confusing to me to think about this being a problem for the last 30 years with report after report after report. So as you're doing your work now, for both of you, Natalie and Houssem, what are you seeing are some of the root causes of this phenomenon, and what do we need to do to really change it?
Okay, if I go just like jump in
Yeah, for
quick.
sure. Jump in.
So I think the cause of the root causes is like we don't have enough funds on healthcare system. We can see like funds that are for construction sectors, etc. But in the healthcare system, we have lack of funds, and one of the causes like the non-willingness of political, the leaders. We need to have political willingness to move forward. If we don't have that, I think we cannot advance. We cannot like change things. So the willingness, political willingness, is the most important thing to move forward.
So what do you think will fuel that willingness? What are some of the ingredients in that recipe that will prompt a politician to become willing and inspired to do something?
The coordination. It should be like a pan-Canadian coordination, efforts between jurisdictions and the different organizations. When we have like collaborative efforts, I think we can move forward. But if each jurisdictions work for its benefits and there is no coordination between them, this is a big barrier that we can see that stop like changing this situation.
Yeah, I also liked what you were saying about the faculty members having more diversity as well, because I can't help but wonder if maybe part of the limitation in the thinking over the last 30, 40, 50 years has been because we don't have enough people at the table to provide different perspectives. So I would add that as well.
Absolutely, and we are serving a diverse population as well. Like now, we see many people coming from other countries. We have
Mhm.
like ambitious people. We have like people, frustrated people. So I think we need to diversify the nursing faculty workforce because we have international students, so they can bring and they can help this population to feel that
Mm.
inclusive in the academia.
Right. Natalie, what do you think about this? I want to hear what you have to say as well about this.
Well, there's so many issues that are sort of welded into this, or woven through this discussion. Um, for me, there are several things that pop up. Houssem said it beautifully. We need political willingness, which is often not present. There's a lot of inertia in politics. Politicians like easy cosmetic changes that will give them brownie points, as we say, rather than real, um, deep transformational changes that will positively impact life of people living in this
Mhm.
country.
Mhm.
And so I think one of the aspects is trying to separate, um, to a certain level, um, politicians from the healthcare system, in the sense that I think we need more watchdogs, provincial and federal watchdogs, to
Mhm.
protect the healthcare system and healthcare workers from yet another politician who wants to just go and change everything. In Quebec, we've had major, devastating healthcare reforms. And this is not just an opinion I'm throwing out there. We have data to demonstrate how horrendous the last healthcare reform impacted the healthcare system, how people, especially going through the pandemic, had a direct impact on the amount of people who died, who were harmed, both healthcare workers and patients, by the pandemic. And so we cannot, politicians are experts in politics. They're not necessarily experts in healthcare. And a lot of our politicians, I find, confuse confidence with competence. And so it's great to be confident, and I'm all for that. But for something as complex and in a lot of ways fragile as the healthcare system, you need experts, and a lot of those experts have to be nurses. We see so many decision tables with only physicians, and physicians are great. We need them to speak on the issue as well, but it cannot be only them, and it cannot be only managers. And as Houssem mentioned, we're the biggest chunk of healthcare workers. So any decision that is taken without the input of the biggest chunk of healthcare professionals and the people who provide the most care within the healthcare system, it cannot be a good decision if you
Mhm.
took that decision without our input. It cannot be, even if there's no malice or involved. If you don't have the right people at the table, you will not be able to make the right decision. And so for
Mhm.
me, that's an essential point. And there needs to be some kind of legislation or rules or something that ensures that.
Mhm.
Because we know you spoke, Trace, at the beginning of the hierarchies in healthcare, and healthcare loves this hierarchy. The PhD, actually, I kept going into the hospital and I felt like I was time traveling back to the 1950s. We have these hierarchies in hospitals, especially, that are toxic, that serve absolutely no one, and that contribute to silence people, nurses, patients as well, LPNs, personal service workers, everybody who's the closer you are to the patient, the less you have a voice. And so that is problematic because it takes information, knowledge from the places where it should be, where people make decisions. So that's without a question one of the central issues for me. We talk to experts, people, and that's important, but you cannot do it without the people on the ground. And that's what reform after reform, not just in Quebec, but in other provinces as well, we tend to centralize, and we have less and less, there's less and less power and flexibility into the hands of those actually giving the care. If you want a nurse to give care, you have to respect her clinical judgment, or his clinical judgment, or their clinical judgment. These protocols, these hierarchies that force us into doing things that sometimes we don't feel is necessarily the best way, that's not just bad for patients and bad for retention, but it's also, it's kind of, it's soul crushing when
Right.
everything that you've worked for, the everything that you've put behind becoming a nurse, getting your education, being there to help patients, And then part of that is taken out of your hands and put into these structures that have no face, that are bureaucratic, that don't allow you to give care the way you know you should be doing it.
Hmm. Yeah, well said, Natalie. Thank you for that. It's just so what is the percentage of nurses for the workforce in Canada? You mentioned that they're the largest group. What is the percentage compared to others? Do either of you know that number?
If I'm sure, it's like around like 30%, right? I'm not sure. I think
I think
I
because you have healthcare workers and then healthcare professionals. So if in the healthcare professional category, I think it's much higher because, for example, in Quebec, there's about 85,000 registered nurses and about, I think, 25,000 physicians, something like that. So
Hmm.
the difference is huge. And if you talk about physiotherapists and um, OT, occupational therapists, and social workers, and all the other healthcare professionals. They're much fewer. A lot of our colleagues, especially in social work, physiotherapy, they need a seat at the table as well. Our healthcare system is very hospital centric and very physician centric,
Hmm.
and so that's one of the issues that hospitals are a much better place. Hospitals really aren't a place for how would I put this? I don't want to get in trouble. Um, Hospitals, the best way to navigate a hospital is if you're healthy, you speak perfect French and English. Ideally, you're white. Ideally, you're male. Ideally, you're not sick at all. Because when you're hurting, when you have any kind of, but I mean, when you
So
think
if you're
about it,
so let me get this straight. So if you're a white male with nothing wrong with you, then you're
then you're the
probably
perfect
you're going to
patient.
be okay. You can navigate a
Yes.
hospital system. But if you're anything else, you're in trouble.
Everything else makes it much more difficult. So being in
Right.
pain, having lower health literacy, things like that. Hospitals are so complicated, have so many layers. It's in Quebec, for example. When I was working as a nurse in the hospital, and I did my time. A lot of us stayed like that as if we were in jail at some point. I did my
Right.
time in the hospital and I do not want to go back because it is very constricting. It is in Quebec, we have forced overtime. So sometimes it literally feels like a prison because they don't allow you to leave, which is outrageous in 2024 that this is still happening.
Right.
Under threats, like if you leave, you're going to lose your license, things like that. This is a common occurrence in this province. And so when I was working as a nurse, I didn't know when the physician would come. So, you do your work and then you're hoping that they'll come before the end of your shift if the patient had questions and things like that. And so there's, as a nurse, we're trying to coordinate all these healthcare professionals, but we don't have access to the schedules, to phone numbers, to, we have so much to do and we have so little authority and power and access to technology, to technological objects to actually do that work so that it's smooth. So we're in a state of constant troubleshooting. Nurses, for me, especially like assistant head nurses, I've seen nurses do everything from, talk to contractors who were um, looking at a room that had, where pipes had burst, to, organizing how to get sanitation to come because the garbages were full. Like there's nothing nurses don't do. And
Hmm.
yet, when you look at hospital records and anything like that, you will not see the record of any nursing work. All of that is, it's hard to explain, it's hard to calculate, but there's nursing notes. But aside from that, there's very little, there's almost no paper trail of what nurses actually do. And so I think a lot of politicians and a lot of managers don't understand that. And so when you have cutbacks and things like that, people don't understand the impact that it has on nursing work because they don't know what nurses actually do, because our hospital structure is made to obscure and make invisible the work that nurses do.
This
Everything we
is
do is lost.
this is staggering for me to hear this. I work in healthcare as well. I've been fortunate enough to work with many nurse leaders, clinical experts, and with the front line that I've worked with as well. And I can't help but wonder, how is it that this goes on and on and on. And the other thought that comes to me as well is that there's no wonder why nurses are leaving healthcare like never before, because as generations are coming up, they're just saying, yeah, no, I'm not going to do this. And so I'm curious, Houssem, in your research, what are you noticing about the the exit of nurses, and what are you seeing that we need to do to turn that around?
Yeah, like in this report, that what we have suggest, like 3 R's, the approach of 3 R's, which is like retain nurses, and then return the nurses who have left the public health and the profession as well, and then recruitment. So this is the 3 R's approach. You know, are very important, because even when we recruit nurses, we need to know how to retain them. So, like this iterative process. So, yeah, we have such like some solutions that we found them like impactful according to the evidence, where we can return back these nurses that they have left the profession, the profession, for example, and the settings. And one, I can say, like the common solution that we suggest is to um, in USA, they call it like the gold standard, like magnet hospital. And we have suggested like to have more accredited, Canadian accredited magnet program that has some different features to improve the work conditions of nurses, so they can come back again to the work if we improve their wages, improve the salary, and improve the conditions, and especially the environment where they are working.
Mhm,
So, and this like may, as I said, like just encourage nurses to come back to the profession, because we are losing a lot of nurses.
mhm,
Uh, Either they go to the private sector, we can see like in Quebec or in other provinces, and then the nurses who are already working in the public sector, they are feeling more exhausted, more overwhelmed, because the number of nurses is like reducing. I can say like day after day, but is really some big problem. And I have heard also like some students, they did not choose nursing programs because they don't want to feel and to live the same thing that nurses now are living. So that's why focusing on retention, returning nurses, and recruiting and the iterative process is very important to leverage this and to pay attention. No, I think this is the big role of the leaders, uh, and to see like what are the different policies that we can
mhm.
revise maybe, and also to put into for to improve nursing well-being.
Mm. So one of the things that I notice about this too is that there's this big push for recruitment, and it's the metaphor that goes through my mind is the idea that we're inviting people to our house, and the house looks nice on the front. They come through the front door and it's actually on fire, and so now they've got to find their way out of the house because the front door's locked now, and so you hand them a water gun on the way in, so that just in case they hit any flames or be able to squirt a little water, and then they run to the back, they find a way, and they jump out. And so one of the things that you're talking about with well-being and the environment is an area that's really important for my work, which is psychological health and safety, and to look at how do we practically create a safe space on the floor in really chaotic circumstances oftentimes, and then what happens when we do? And so I'd love to hear your thoughts on this, Natalie. How do we create a safe space, and how should nurses do that in the midst of this thing that's called healthcare that is on fire right now?
Um, so that's a broad question, and it's multifaceted, and there's not just the one solution, right? I think that's one thing we have to take out of our minds. Our healthcare system, and even nursing as a profession, is obsessed with standardization and one size fits all. That is not a good way to move forward. One
It's a
size fits
prescriptive
all
approach.
usually,
It's a prescriptive
yeah.
approach, right?
And we got to stop with that. We have a clinical judgment. We don't need a prescriptive approach. We need guidelines, yes, but we need to have some flexibility and some freedom to adapt things to our own reality. Whether because it's not the same if you're working in a hospital in Montreal or a dispensary in Nunavut or a primary care clinic in the prairies or there are so many different places where nurses work. That nurses work pretty much everywhere. I mean, from schools, workplaces, hospitals, clinics. So we have to that's a good thing. That's not something we should try to, obscure with, generalized practices or excessive standardization. So that being said, creating safe spaces, nurse retention is not rocket science. So Houssem is doing extremely important work for our politicians that really translates what we need into language that they can understand. But at the same time, you know, politicians understand what retention is. We've had our premier here justify an increase in our MP salaries, for example, a huge increase, 30%, by saying we want to attract the best people and we want to make sure they stay, because it's not an easy job. That is what retention is all about. Recruiting the right people, making sure they stay. So he understands that. But when it comes to nursing, our politicians become, all of a sudden, it's like, what could we possibly do? I have no idea. We're, completely helpless in front of this unexpected crisis. And that, again, ugh, it is exhausting because nurses we're not an alien species from another planet. We are human beings. And so what is good for one human usually works for nurses as well.
Right.
So the main thing is ask nurses what they need. Again, in different units, it might be different things, and ask them in a way where they don't feel coerced. So in certain places with really strict hierarchies in hospitals, for example, maybe it shouldn't be the immediate supervisor, or it could be done in an anonymous way. The whole error reporting from the airline industry, for example, is a good example of that. It's anonymized. We've taken, error reporting in hospitals right now in Quebec, at least. I'm not sure it's the same in other provinces. We've taken everything from the airline industry except the making the
Anonymized.
content anonymous. And so if you make a mistake, I have to write what my mistake is, and then I gave it to my boss, and then she looks at it, or he looks at it, or they look at it. And so that's usually not a good idea, right? That does not encourage reporting. It's not because nurses or managers are bad. It's just there's a conflict of interest there. And to avoid the conflict of interest, it should go to a third party that's more neutral. So it should be the same with retention measures. So in some cases, the pandemic, I think we're all very much damaged from the pandemic. I went back to long-term care during the first wave. It was the worst professional experience of my life. I still have nightmares about it. And there was no support for us during, before, after. There still is nothing. And, I know a lot of nurses who left because of that. They were just too injured morally to continue. Montreal was really the epicenter. And the things that we saw were stuff nobody should ever see in their lifetime. And so one of the solutions to that, to improve our well-being, and this is what you should not do, was to put more work onto nurses. So instead of providing, for example, a social worker come on each shift for a couple hours to chat with the staff, to, exchange, create a safe space, as you mentioned, social workers are great for that. Social workers are excellent therapists, and they're our colleagues, and they know what we've been through. And so that's one of the good ways to do that. But instead of providing somebody else, they decided they were going to train nurses on the ground to detect issues with their colleagues. And so now, on top of going to work, on top of being morally injured, on top of being burnt out, now you have the responsibility of the well-being of all your coworkers, the mental well-being of your coworkers. So again, the solutions are politicians, and often that high-level managers propose are putting more responsibilities onto nurses rather than allowing them to speak to somebody else. Rather than bringing in help, it's heaping again onto the amount of responsibility. So now we're responsible for the well-being of patients, for respecting hospital policies, our code of ethics, for managing families, managing our coworkers, managing the healthcare team, and now we're also responsible for the mental well-being of all our coworkers. That is not a good solution. That's not to say if people do want to get training, that's fine, go for it. But overall, it's not about putting more onto us. We're already half broken. It's not completely broken. We need help. We need support, and that support should not be, oh, here's something else you should do that will help you. Do more yoga, go jogging, do a journal.
Yeah, I think if we talk
stress ball that I'm going to give you.
here's a stress ball, and while you're at it, build some more resilience. No, that's not gonna. In fact, I think that most nurses I talk to, and even clinical leaders that are also nurses too, are fed up with that, and it's really at a breaking point for them in terms of their ability to maintain their composure. Because the fact is that what you're saying is true. We're just downloading more and more work. It just is really surprising to me that this is happening, I guess, because I know that I've been cared for in our healthcare system by a nurse or nurses on several different occasions throughout my life. I've had nursing experiences that have really saved me in so many different ways. My daughters have also had those experiences. My granddaughter has had that experience. I just Where is the humanity in this for those that are making decisions like this to know that, hey, that I could be in that situation? Is it just that they have enough money they can buy their own healthcare, or what is going on there?
But just one thing about what you said. So you've had experiences with nurses within the healthcare system. And what I think a lot of people need to understand is that our healthcare system is not a humanist healthcare system. It's not human. What makes it human are the nurses.
Right.
And so nurses often protect patients from the healthcare system, from the structures. And we have to start seeing it that way because
Mhm.
we're losing nurses and now we're seeing the consequences of that. So we have to look at it as a very sort of it's a complex problem. It's a social problem, and part of the reason has to do with, for me, part of the issues are feminist. There's jobs that are historically conceived of as women. Both of you are
Mhm.
nurses and you're men, but society sees nursing as a woman's job, and a woman's job is not often not, and it's the same with teachers and
Mhm.
many other professions and jobs that are mostly women. People see it as something that we owe society, right? So women caring is something that we owe society. So it's ridiculous to have to pay a woman for that or pay high wages or things like that. And so there's a culture shift, I think, that we need to, and especially within the healthcare system, we need to lead that, because the healthcare system is behind even society as a whole
Yeah.
in terms of equity, in terms of, we've spoken about diversity, and our healthcare system is very racist, very colonialist, very sexist, and we see that in the
Mhm.
hierarchies that exist, in the faces that we see of the healthcare system. And so there's a lot to think about, but primarily we have to think about human beings, and
Right.
we have to stop looking at people, patients, nurses, whoever, as Excel spreadsheets that you can just move numbers from one column to the other. That is never going to work. And when we talk about maintaining the status quo, we're not even maintaining the status quo, because the status quo is so bad that it keeps degrading. And
Right.
so by doing more of the same, we're actually making it worse.
Mhm.
So, the crisis that we're seeing right now is highly preventable, is entirely man-made, but it's also entirely fixable.
Mm.
So because it's because of humans, right? The solutions are also fairly simple. Apply the vast knowledge that exists in management science, in retention studies, to nursing. And that's what nurses want. That's why there's never been so many nursing strikes in the history of the world than in 2023, for example,
Mhm.
because we're sick and tired. So either we leave or we strike. We're voting with our feet
Okay.
because there's no other way to be listened to. We try, nurses, I've been part of committees that have written white papers, recommendations, simple solutions at very low cost, for years and years and years and years. And managers, politicians have always looked at me like, oh, you're such a sweet nurse. How wonderful that you're interested in these things. Then we'll tap on the back, and then, you never hear from them again.
So we need
So
systemic transformation that you're talking about. And so Natalie's suggesting that we do something very novel. We actually ask nurses and then we listen to them. This is a novel concept. I love it. It's so simple, and management science would tell you the same thing. Let's talk to the pointy end of the business and listen to what they're saying, and then create systems that support them to do what they need to do. Houssem, what are your thoughts with this and what we need to do to retain nurses and also to create safe spaces?
Mhm, absolutely, yes. Like I've talked earlier about the three R's that we have: retain, return, and recruitment. I'm going to add the four R, which is respect. So
Mm.
when nurses feel respected, they will feel safe. They feel like they are included. And how we can do respect nurses by dedicating mental health days. If they don't feel good, they can have 1 or 2 days, to take just to re-energize themselves. We can also look at the workload that they have. So this, I think, very, very important nurses to feel safe in the workplace. Also, they have more control on their agenda, I can say. The schedule. Sorry, yeah, the schedule. They have more control of the schedule, so they can work. Because, because I come from Tunisia, and nurses there, they work 7 hours, from 7 a.m. until 1 p.m. and then there is another nurse will take the shift. So when I came here to Canada, I was said, wow, nurses are working 12 hours. I didn't understand the concept at the beginning, but this, even we are human after all, right? So we cannot work all these hours without thinking, because any nurse, I think he has, some other problems, family or whatever. With the work, it's a lot. So giving nurses the time, respecting all these things is very important. So I think the first thing, the fourth R, is very important, the respect of nurses. Respecting as well the salary that they have, because I have heard, I know that for professors or even from some nurses, the salary is so low comparing to other healthcare workers and comparing even to other sectors. And even though they are doing a big job, look at the COVID-19, what nurses are struggling, in the front line and trying to protect people. So all this, I think, may let nurses feel safe and heard when there is a decision. Just recently, I have appointed the chief nurse at the federal level, Dr. Lee Chapman, which is good, but this there is a bigger gap before that. I think the last one was 2006, something like that, if I'm not wrong. And now in 2022, 23, they have appointed again. So I think that we need to. This is a good initiative. I think that we need to let this initiative sustainable, not just for few years, but I think we need this to implement nurses in the decision table, to feel respected and to see how we can help nurses in the front line. So I think just to sum up, the fourth R, respect, is very important to feel safe within the workforce.
Thank you for that, Houssem. So one of the things, and we'll shift gears now and talk a little bit about what we might, do on the floor to close the gaps between the front line and clinical leaders and managers so that we have a more relational system or more relationship equity to be able to do the complex work that's going on there. Because right now, there is big separation between those groups. The front line is kind of on their own and often are talking about how they need more support and they're not getting it and they feel isolated and alone. There's lots of moral distress going on there. You've got clinical leaders that were nurses at one time, but now are patient care coordinators or nurse educators or specialists, and they're in the middle trying to bridge between the boardroom and the front line and feeling crushed, not really feeling like a bridge. And then you've got the managers that are trying to appease the executive team and do what they need to do, and all of them are in these silos. And so, to your point about respect, one of the things that I've designed is this safe space process where we answer 3 fundamental questions together, which is, what do I need to feel safe? What do I need to be open and learn? And what do I need to feel respected? Because if we can understand that, because what I need for respect might be different than what Natalie or Sam needs. So we need to understand that, and we need to be able to have that perspective clear for us, but also to listen to other people so that something new can happen. And when we do that, we start to see these pockets of I guess they're pockets of examples of what can happen when people feel safe inside that really complex, challenging system. So I'm curious, Natalie, in your experience, and also for you as well, Houssem, do you have any experience with witnessing that kind of a safe space on the floor? And what kind of things happened when that was there?
So for me, I'm working for free now. I'm a volunteer at a clinic because I love it so much, and because I feel so safe there. It's one of the best places I've ever been, and I wish I could give more hours, but it's a wonderful place to be. And that being said, I think all nurses should get paid.
Of
I'm paid as
course.
a professor, so I make I make a good salary, and I'm not I have nothing to complain about. But nurses, I mean, the 4 R's that Houssem mentioned are so important and so simple. Retain, return, recruit, respect. And I know nurses are so proper and we're always allergic to talk about money, but money is important. Your salary is a reflection of the value that society places on your work.
Mm-hmm.
And nurses in this country are vastly underpaid for the work that they do, but also the amount of responsibility that is on their shoulders. And so if there's one thing that the pandemic has taught us, and this is a quote from my colleague Amélie Perron at the University of Ottawa, she told me once, one of the things that the pandemic really showed is that nurses really are worth $100 an hour. And I'm not saying we're all going to get a wage increase of $100, although I think we do deserve it. But why are governments willing to give billions of dollars to private agencies and not invest that money into nursing? And so I think we're so used to asking for little things. I've been in so many committees with nurses who have told me, oh, no, we can't have any proposals that cost money. We shouldn't talk about money. And I think we should ask for money. We deserve it. It is essential, and there's only so far we can go without money, and that goes through salaries, through professional supports, where they're having social workers on the ground and things like that. Our governments, there is money for healthcare, and if we don't ask it, we're never going to get our share. So that's one thing. We need to feel empowered. We need to feel empowered that we deserve things that cost money. Our governments are willing to throw money at all kinds of things. And so we have to force them to make choices that reflect the value that we bring to the healthcare system as well. So I think that's something we have to sort of unbrainwash ourselves or teach ourselves to stop doing. We are so allergic to asking for money, to the point where sometimes we don't even ask for something because we're too afraid the decision maker is going to say no. Because it costs money, or whatever movie we've started making in our heads about what the response will be. We are worthy. We bring immense value to the healthcare system. So part of it is our own vision of ourselves, knowing our worth, and that's a big part of what I do as activism, and encouraging nurses to speak up politically, even when they don't feel they have necessarily the words or the expertise. It's something you have to practice. It doesn't come just like that. You're not just born a perfect politician. It takes practice, and through experience, you gain a lot of knowledge and especially a lot of confidence. So that's one thing. For respect, again, we have to stop with the standardization and look at processes instead of results. So, for example, one hospital here in Quebec, one of the big hospitals, one of the units that had the most forced overtime and was bleeding nurses because of that, through a period of 18 months with committees and consulting, real, authentic consulting of the nurses on the ground, they were able to eliminate that completely. And it didn't start with recruitment. It started with retaining the nurses that were there, asking them, what do you need to stay? We don't want to lose you. What can we do? Coming from a very humble place, not from a place of authority and coercion. And that was a great success for that hospital. But instead of looking at the end product, saying, oh, we did this, and then applying that, we have to look at the process that led to that. So it's not just about the final recommendations, it's how they got to that place. And that's what we need to start emulating, because a lot of places are going to have maybe different recommendations at the end. But what's going to be really important is the process that they went through, and the collaboration and the leadership that we've nurtured of nurses on the front lines. Because leadership on the front line is often disruptive. And instead of supporting it, hospitals often try to squash it most of the time. So disruptive leadership is what we need for transformational change. Or else it's going to be more of the same kind of, management jargon, lean, Six Sigma, whatever, and it's not going to lead to profound change. It's going to be more cosmetic change. It's going to be stuff that looks great on paper, on stats, but that's going to have a terrible impact on the ground. So disruptive leadership is a good thing. It's not a bad thing. And a lot of disruptive, I got in trouble so many times, but I'm very stubborn, so I refuse to let that get to me. And it took me a long time to get where I am, but I think it was through every now and then there was a nurse leader, a nurse manager, very few and far between. There was a few who looked at me and instead of looking at me as a troublemaker, looked at me like somebody who could help bring about good changes.
Mm.
And so that made a huge difference because it's normal to have nurses that are angry, that are sad, that are depressed. We can't force nurses to, well, you can talk to me, but I don't want to hear your anger. I don't want to hear your distress. And we use words like, oh, you're not professional, or you're not behaving, or you're not proper, or whatever. But when you've seen somebody die for reasons that could have been prevented, when you miss out on your child's birthday or their first steps or things like that, of course you're going to be angry. And we have to accept that there are emotions that we go through that make us do the things that we do, and we have to respect and validate those emotions, even when it's anger, even when it's hard to hear sometimes. And our healthcare system does not usually like to do that, but that's one thing that I find in management we really need to understand, and be much more accepting of the emotions that we're going to feel. And for me, the managers that are the most successful that I know, they have an open door policy, and anybody on their staff can come in and cry and vent and be angry. And that is a safe space. They don't feel like they're going to get fired, or they're going to get the worst shift, or they're going to get the worst patient assignment, because they express their feelings about something important that happened that affected their work and that affected their mental well-being.
Thanks for that, Natalie. And Houssem, what about you? Have you witnessed any safe spaces in your area of influence? And if you did, what was that like? What happened?
Yeah, absolutely. Like what I can say, according to my experience and what
Mhm.
I have witnessed, like that the safe space, the opposite is of safe space is like incivility and civility within the workplace. So I think that to implement this safe space, I need to see what are the main cause of incivility, of this, which is incivility. Incivility, we talk about the toxicity between colleagues, the toxicity between managers and nurses, etc. So this is a big thing that I have witnessed and really had a big impact on the nurses and the workforce. And the other point, like we need to hear the nurses what they think about the programs, for example, that we implement within the hospital. For example, we have the program of mental health support, and nurses don't go to this because they are feared to be stigmatized.
Mhm.
Okay, so we
Mhm.
feel that we offered nurses this program, but which is wrong. I mean, you need to see how nurses would like to suggest if they need to have this program or to have more private or individual meetings, because they are feeling to feel stigmatized, and many they don't want to reach this program. So with the results that nurses will stay always, I mean that if they don't go to this program, for to improve their mental health, they will not do it because they are fear of that. So we need to hear the solution that comes from nurses, what they suggest to improve and to implement a safe space. Like now with the Mental Health Commission of Canada and the Canadian Health Workforce Network, we are developing a toolkit, and which is nice in this toolkit that we have some different teams, and then try to see if they are ready to implement these different resources and what are the challenges and how they can implement this different resources of our toolkit. So I think in this way we can know how we can develop a safe space for these people. It's
Mm.
not like as a leader I can understand that, no, because this is their lived experience. They can come with innovative solutions, and we fund these solutions to improve their safe the workplace.
When is the toolkit going to be available through the Mental Health Commission of Canada? Do you know?
March 20 something. It's
Okay.
like in March.
Yeah,
I can
late March.
note you once this toolkit is ready, so I can
Yeah. Yeah, that's great. Probably will release then anyways. So just wanting to bring things to a close, but I have a question for both of you. I'm just thinking about the managers and leaders and clinical nurses that are listening right now. And what would be one tip that you could give to those managers, those leaders that would help them to sort of keep going and navigating inside this really complex problem right now? What would be one thing, word of encouragement that you could give them?
If I jump in quick, I need to say that leaders need to value their healthcare workers and love them, because I know that some nurses stay resilient and don't leave the profession because they have good leaders, even though they are feeling overwhelmed by work. But when the leader are not, they are not taking care of their nurses, they will leave, their work. So
I'm so
I
glad
think
that I heard you say the word love. So what when you observe a leader loving their nurses, what are some of the things that you see and hear?
I can see like the nurses are feeling well, and they feel like feel like safe in their workplace.
Yeah.
You know that, for example, when they need to take some days, they will take it because the leaders take care of them. And if nurses need to, for example, to continue their education, they will be sure that they will have this opportunity because leaders love them.
Mhm.
And if they need to take a vacation because they don't feel good, so they know that they will say how the okay from the leaders because they know the leaders love them. So this is
Mhm.
like how why love is very, and love is a big word, and is like something very, very important to love each other, you know.
Thank you, Houssem. Natalie, same question for you.
So one piece of advice, I mean, my main thing would be know your worth and don't settle. I think that's important. And another thing would be the hierarchies in healthcare. The power that is put into them is often power that we give to those hierarchies, and
Mm.
so it's often I find nurses imagine consequences to possible disruptions they can cause, and those consequences are vastly over imagined. We have very fertile imaginations, and part of the reasons the hierarchies remain so fossilized within the healthcare system is that there's very few challenges to them because they are so menacing. They're so scary to question and challenge. But once you do actually start questioning and challenge the existing hierarchies in healthcare, we're quick to realize that they're like, a castle of cards. They just they're made of dust, really. They're only as strong as the power we allow them to have over us. And so that's part of educating ourselves to our worth and to understanding that these hierarchies serve no one. They are not good for patients, they're not good for healthcare professionals, they are good for nobody. And questioning them, although it is scary when we start it, and it's important to find allies and things like that, but it's not as bad as you think it is. Believe me, I've been through it, and I've gone through it with a lot of colleagues and friends, including Houssem. Actually, we've had the joy of working together a few times. It's not as bad as you think it's going to be. So go out there and disrupt some shit.
That's
That's great. All right. So, just in closing, how can people get in touch with each of you if they'd like to know more about your work and support you in what you're doing?
uh,
Email, Facebook.
yeah, for me, I just like write my name, Houssem Adeen Ben Ahmed, Houssem, space Eddine, space Benahmed. So just like I have email, I have like LinkedIn, Facebook, wherever. So they can, if
Mhm.
they're interested in this, they can contact me. So we can offer them, like some ideas,
Sure.
expertise,
Yeah, that's great.
Same
and
for
also,
me. Google me or ask Houssem about my email. He'll give it to you.
yeah,
All right. Well, I'll put your LinkedIn profiles on the bottom of the
Perfect.
show notes for everybody as well. Yeah. So thank you so much for your time and your passion. I really appreciate your work, Natalie and Hussein, what you're doing. And please keep doing it.
sure. And
Thanks for
like
having us.
Yeah, like I'm so pleased also that we're gonna work. I'm gonna work with Natalie in a great project, which is our like network that I'm developing. This like to bring nurses from different countries, including Canada. So I'm so happy that
Say a little bit more about that project. What is the
Yes,
project?
please.
yeah, so this is like research network, a virtual research network that brings nurses, nursing clinicians, students, professors, managers, and leaders within the same table to see like how we can coordinate our efforts to improve the healthcare workers. So this is called the Collaborative Alliance of Research and Education for Nursing Empowerment, CARE4NET, the acronym. And this is to improve practices within MENA region, the Middle East and North Africa, in collaboration with Canada. So we
Oh,
would like to
amazing.
put together because I believe that we can learn from each other, so countries can learn from each other. So that's why it's the project, the network will be launched March 2nd. So it will be like Facebook Live at 2 p.m. And then we're gonna celebrate that with Natalie and the others here in Montreal in person.
That's amazing.
Be
Amazing
there.
work. Yeah. So please give me those links so I can add those to the show notes as well. And again,
Sure,
thank you both for being here.
sure. Thank
Thanks
you
for
so
having
much
us.
for your work.
Yeah,
Thank
you're
you so
welcome.
much.
Thank you so much for listening to the show. And if you have any comments or questions, please reach out to me on LinkedIn. I look forward to seeing you next time, either online or in one of our programs. And until then, remember to be a safe space. Thank you again for getting to the end of this podcast. And if you enjoyed this and you found that there was value in it for you, my invitation is for you to subscribe for future episodes that come out weekly on Tuesdays. Thank you again, and I'm looking forward to being with you next time. Now remember to be a safe space.